All right. Thank you very much for having me. I'm happy to be here at UCI. I was a master's student back in 1990. I got a master's of science degree in preventive medicine from the Ohio State University in Columbus, Ohio. And at the end, if we have time, I'll go more about how I got to the path where I'm at now. I have about 20 slides to go through that will give you sort of the history of tuberculosis, where we were, where we are, where we hope to go. Most people wonder, why do I even have a job? I thought tuberculosis was gone. And tuberculosis was one of the leading causes of death, especially infectious disease deaths throughout history. Now, we're going to start off with some brief history on tuberculosis, then go through why it's still around now and why I still have a job. So again, TB goes back throughout the ages. Time and time again, it's been around. They found it in the mummies of ancient Egypt. Queen Nefertiti was reportedly had died of tuberculosis. Ancient Greece, they debated, what is the cause of tuberculosis? It wasn't called tuberculosis back then. They called it phthisis, which means wasting. One of the hallmark features of tuberculosis is that people waste away. And tuberculosis, or TB, has had many names throughout history. Again, in ancient Greece, it was called phthisis. And the greats debated, what is causing our people to die? We got Hippocrates, who believed it was heredity. You were born with tuberculosis. Aristotle disagreed. He believed the disease was contagious. The debate went on and on, back and forth, because nobody knew why. They just knew their people were dying. So throughout history, throughout BC, into AD, throughout the early centuries, people continued to die of tuberculosis. The only thing that really changed was the name. It went from phthisis to consumption. Again, consumption because it consumed your body. Your body wasted away. The bacteria ate you up from the inside out. It consumed your lungs, made you die. Again, it was a leading infectious disease killer. So as time went through, there was not many scientific advances. They could just postulate, what was the cause of tuberculosis? Why were our people dying of tuberculosis? It wasn't really until the scientific advances came about that people got more clues as to what was causing tuberculosis. So back in 1689, Richard Morgan, through the microscope, saw these tube-like structures, these tubercles on the right. And he postulated, he stated that these tubercles were always present in consumption. Looking at cadavers, looking at tissue under microscopes, he always saw these tubercles. So his thought was these were the cause of tuberculosis. But not many people believed him. They say, no, it's due to hereditary. No, some other factors affecting the person. So largely went unnoticed. In 1720, another scientist tried his luck. Benjamin Martin proposed that consumption could be transmitted by airborne, and I love this quote, wonderfully minute living creatures. So again, putting forth a contagion theory, that there's something that gets within our body that's causing tuberculosis. But again, this was not widely adopted. People wanted proof. Show me the evidence. In 1839, we finally got the term tuberculosis. So we went through phthisis, we went through consumption, and in 1839, it became the current term tuberculosis. And it wasn't really until 1865 that a physician was able to demonstrate that TB was contagious. And how he did this was he looked at a fresh cadaver. He looked at lots of cadavers. But what his test was, he found a cadaver, someone who just recently died of tuberculosis, found out within the lungs where that pocket was in which the germ was replicating, took a sample of that from the lung and injected it into live rabbits and watched to see what happened to those rabbits. And to his astonishment was that these rabbits developed tuberculosis. And then they died. So he tried it, can rabbits give it to rabbits? That worked. cadavers to rabbits, that worked. So again, this was our first contagion theory proof. So the scientific community became more excited. Again, we're still at the #1 infectious disease killer in the world at this point in time. So we finally have an idea that it's airborne, and it's something that can be passed from person to person, or person to animal as well. So it wasn't until March 24th, 1882, that we had the breakthrough. And for tuberculosis, this is the day of infamy. In fact, every March 24th of every year, we celebrate World TB Day, because on March 24th, 1882, Robert Koch discovered Mycobacterium tuberculosis. This was a causative agent of tuberculosis. So this was a milestone in science around the world. We finally had the causative agent of tuberculosis. And later on, 8 years later, he developed what's called tuberculin, the purified protein derivative that is the key part of our TB skin test. However, it wasn't until Charles Mantoux in 1908 who was able to put that into use to develop the TB skin test. Probably all of us in this room have had a TB skin test. Again, it was developed in 1908, and it's still in existence today. 110 years, or almost 110 years later, we're still giving the TB skin test because it's still the most widely used around the world. In fact, last month I had mine. Every year as a healthcare professional, I had to get a TB skin test. Now, luckily, there are some new ones that have come out, some blood tests, but we still use, for occupational purposes, we still use the skin test to see if we have TB infection. So, a lot has happened over this time, 1908, but the thing is, people are still dying of tuberculosis. It's still the leading cause of death in the world. So it's still plaguing society. So it became a romantic disease. It was called the white plague. White not because of race or ethnicity, the color of your skin, but because of what tuberculosis did to your body and created in the color of your skin. The white plague was a romantic disease. People had it, they knew they were going to die from it. There is no cure for tuberculosis, and it's a slow-moving disease. So people thought it was a good death. It took a long time to die from it. You could get your affairs in order. You could do your will, figure out who you want to give your money to, who do you want to take care of your kids when you die. So it gave you the luxury to plan for when you were gone. So they considered it a good death. It also represented spiritual purity and temporal wealth. I know I'm dying, but I know I'm not going to die today or tomorrow. I'm going to die in the future. I can create my bucket list and do everything on my bucket list before I die. So it was a good death. It gave me the wealth of time before I died. Being pale was in fashion. Again, that's why they called it the white plague. It was plaguing society. If you were white and pale, the body's destroying your inside from the lungs to other parts of your organs. It's taking your blood supply. It's taking all your nutrients. You're wasting away, but you had that nice white color. So that was in fashion. And it was popularized as a disease of the artists. Some of the greatest plays, operas, books had a TB subject. La Traviata by Verdi, Les Mis by Hugo. And even in the 2000s, for those who've seen Moulin Rouge, the main character actually died of tuberculosis. I don't know if you've seen the movie, but she's coughing up blood. And they know that she's going to die. It's just a matter of time before she dies. She's coughing more. She's sweating more. She's coughing up more blood. She's tired. She has tuberculosis. Again, the leading cause of death for that time. So it was romanticized because there's nothing else you could do. You're dying. If you have tuberculosis, it's an incurable disease at that point in time. If you do have it, what do? You could just sit at home. You could do your bucket list, or you could go to a sanatorium. So the sanatorium movement began in Europe. The first US sanatorium was in Saranac, New York in 1885. And the sanatoria flourished from 1870 to about the 1930s, when the more scientific advances came up and there was a hope and a chance for a cure. But people would go to the sanatoria, usually as in very nice places. High elevations were thought to help. Sunlight was thought to help. Fresh air was thought to help. Good nutrition. So, some gentlemen here relaxing as they hope that these natural events or natural conditions would ease their transition to death. And hope, some people spontaneously recovered, but that was very rare. In the bottom right-hand corner is a place called A.G. Hawley Hospital in Florida. I had the fortunate ability to work there before they closed in 2012. But this was the last remaining US sanatorium. Again, mainly palliative care, mainly a place for people to spend their last days, not at home infecting others, but with other people who could commiserate, could sympathize with what they were going through, and hopefully, have a peaceful end to their lives. But back to science. In 1906, there was a vaccine that was developed, and it's still in use today. It's called the BCG vaccine. And it did have some early success, and it does have success with a certain population right now. It's usually given shortly after birth. Because what it does, it spurs your immune system to create antibodies to fight off the Mycobacterium tuberculosis. So it's especially effective for newborns and children within the first year of their life in countries that have a high morbidity and mortality from tuberculosis. So a lot of our third world countries still give BCG vaccine. But the problem with BCG is that it wanes over time. Even if you get a booster dose, it doesn't prevent you from getting TB infection or TB disease in the future. Again, it's just a boost of that immune system for that early time period. So in the United States, we don't give BCG vaccine for two reasons. One, we don't have the high morbidity, so our newborns are less likely to become infected. And number two, it makes our TB skin test positive, and we lose that tool to detect TB infection. So one of the issues that we have in the TB world is when we do a test for tuberculosis among the foreign-born, sometimes they are positive, but we don't know whether that's positive because of the country that they came from and that they received BCG vaccine, or positive because they were infected with tuberculosis. Fortunately, there's a new blood test that is around that is not affected by the BCG. So in the TB world, we recommend those who have the BCG vaccine get what's called an IGRA, an interferon gamma release assay blood test, the TB blood test, that is more sensitive and specific than the TST and is not affected by the BCG vaccine. So again, we have, in 1906, people are still dying of tuberculosis. It wasn't until 1946 when the era of effective TB treatment began. So streptomycin, an injectable medication, was found to be the first medication effective against killing Mycobacterium tuberculosis. And this was a huge advance, one of the greatest advances in the world. So again, they began giving people streptomycin, and people started getting cured. So this is the first time people were actually starting to get cured from tuberculosis. But the Mycobacterium tuberculosis is a very adaptable mycobacterium. Inside your body, it's a powerhouse. It keeps reproducing itself. But its genetic material changes very easily. It mutates very easily. And what they found was it easily became resistant to streptomycin. So streptomycin could cure some people and not cure other people. So it wasn't until 1952 when they came up with isoniazid that we really saw a true advance. Isoniazid was the first oral medication to combat TB. And what they found is when they used it in combination with streptomycin, it cured much better than any one of them alone. So combination therapy became the thing to do in the treatment of tuberculosis. The thing was, drugs really weren't coming out at a rapid rate. And really, it's taken the next 4 decades past that point to find 4 good drugs that treat TB. And these are actually the 4 drugs we use now. We use isoniazid, rifampin, pyrazinamide, and ethambutol. So if somebody is found to have active tuberculosis disease, these are the 4 drugs they first go on. Again, the reason we use 4 drugs is that the Mycobacterium tuberculosis easily mutates. So it can be resistant to isoniazid, and the rifampin can kill it off. So each of the drugs has a different specific site on the bacteria that will help it die. So by using 4, we can try to kill all of those colonies of Mycobacterium tuberculosis that are in your body. And the good thing is by using 4, we can reduce the treatment time to as low as 6 months for somebody that is not resistant to the organism. So this would be 6 months. What happens is you take all 9 of these, at least 9, it depends on your weight, you could take more, but the standard dose is 9 pills once a day for 6 months. And we have a program called Directly Observed Therapy, in which I have staff that actually go to your home, go to your workplace, go to wherever you want to meet with them, and we watch you take your medicine. Because I don't know about you, but 2 weeks of antibiotics, I'm forgetting when I'm feeling better. So 6 months of medication every day is needed. So this is the only way that we can ensure that people take their medication for that long of a time. So in Orange County, directly observed therapy is required for all TB cases. And we have over 90% treatment completion and cure rate in Orange County. So a little bit about why is TB a public health threat? So that was a history, that's the medication. Why is it a threat? Because it's an airborne disease. It's a coughing disease primarily. You cough up sputum, so it's not just liquid spray. Sputum or phlegm is usually yellow or green, thick, mucus-like. You have a cough that lasts at least 3 weeks. You may cough up blood, depending what the bacteria is doing to your lungs. And it does not respond to other antibiotics. They can't give you a Z-Pak to cure tuberculosis. It has to be, again, the 4 drugs that we use is what we know will cure you from tuberculosis. Other symptoms include unexplained fever and or chills, night sweats, unexplained fatigue, unexplained weight loss unrelated to dieting, a loss of appetite, and chest pain. So these are the hallmark signs and symptoms of tuberculosis. How is it spread? The TB germs are spread from person to person through forcing it from, if I have infectious TB, in order for me to pass it to you in the audience, I'd be coughing or sneezing or singing. But it's not as easily passed in a short amount of time. I would have to spend frequent and prolonged time with you to pass tuberculosis. So just in a lecture hall like this, during a 50-minute lecture, I can't pass tuberculosis. But if I'm living with you in your household, or if I'm at work with you and talking to you every day, our guiding rule is that it's about 8 hours of cumulative exposure. That, if you're able to breathe in the air that I'm coughing out for an 8-hour or more period, cumulatively, we would consider you as a contact to a case of active tuberculosis. If it's under 8 hours, again, if it's not frequent, if it's not prolonged contact, then we would not consider you a contact. And we do this every day. Again, I'll talk about how many cases we have in Orange County, but we do these contact investigations on a daily basis, asking people, where do you work, where do you go to school, who are you with, who's in your household, who are your friends. And we try to gauge how long they spend in time with those who they have contact with. And only those who have frequent and prolonged contact do we follow up and investigate for TB. So inside the body, the TB germ is a powerhouse. Outside, it's actually pretty weak. It's killed by sunlight, and when it's not floating in the air, if it hits the floor or the wall or any other inanimate object, it dies. So outside your body, it's a pretty weak germ. Inside your body, it's a different story. You cannot get TB by just touching, by sharing food or drinks, casual contact, linens or clothing. It's not as easily passed as, say, influenza or measles. Again, frequent and prolonged contact. So the two things we want people to know is that there's two types of tuberculosis. There's a TB infection stage and a TB disease phase. Usually about 1 in 10 people who have TB infection would move to TB disease over the course of their lifetime. The other 90% would just stay as TB infection. So once the germ gets inside your body, you breathe it in through your nose or through your mouth, it goes into your lungs. And it usually sets up shop in the top part of your lungs because that's where you have the most oxygen. And the TB germ, the bacteria, needs oxygen to live, to replicate. But what it does, it sets up a little factory inside of there. It creates a ball around itself. And within that ball, in your upper lobes, it creates more and more of itself. And it feeds off your lung tissue. So as it, if it's not treated, it just eats more and more of your lung tissue. Starting at the upper part and working down. So, I mean, depending on how long people wait to get seen, we've seen people that, on an x-ray, their whole lung is white. It's created scar tissue. And what happens is after it eats away your lungs, your body comes in, fixes it, and creates scar tissue. And then you lose that part of your lung's ability to do oxygen exchange. So that's why people get shortness of breath and chest pain or cough up blood, because the bacteria is eating up the parts of your lungs. So with TB infection, you're not sick. Your TB skin test is usually positive. Your chest x-ray is usually normal. If they do a bacteriologic laboratory test, that would be negative. You cannot spread TB and TB infection. And we're able to treat TB infection to cure with either 1 or 2 antibiotics. Historically, we've used isoniazid for 9 months to get rid of that TB infection. But in the past few years, there's been a new scientific development. And a 2-drug regimen of isoniazid and what's called rifapentine. You take this regimen once a week for 12 weeks, and the TB infection is cured. So it is the same as isoniazid for 9 months, but you're taking it once a week for 12 weeks, and then you're done, versus isoniazid, which is 1 pill every day for 9 months. So we're very excited about that regimen. It's a new regimen, and it's proven to be very effective. It requires a lot of pills. It's taking, again, probably about 9 to 10 pills a day. But if you have TB disease, you're taking that amount of pills anyhow every day during the week instead of just once a week. So that's our scientific advance for TB infection. For TB disease, again, that's when it progresses from TB infection to when you're actually sick. So you usually have a positive skin test. You have the symptoms I talked about before. You have an abnormal chest x-ray. You have a positive sputum. Again, sputum is that phlegm, the green or yellow you're coughing out. We can send that to the laboratory. We look at a smear to see if we see the bacteria on smear. If the smear is positive, then we isolate you. We take you out of circulation. We take you out of school. We take you out of work. We leave you in your home. But we take you out of all your activities until we treat you and that smear becomes negative, which can be anywhere from 2 weeks to 2 months. If the culture is positive, we will look at the susceptibility to see if it's sensitive to all the drugs. If it is, then we'll keep you on the 4 drugs. If it's resistant to isoniazid or rifampin, then we'll switch drugs. If it's sensitive to isoniazid and rifampin, then we'll take the other 2 drugs away. And again, because you're infectious, you may spread TB, and it's curable with multiple antibiotics. So TB infection and TB disease. So in Orange County, the most cases that we had was in 1981. We had 531 cases of tuberculosis disease in Orange County. Fortunately, that number has been dropping over the course of the years. In 2007, we were at 217 at a case rate of 7.3 persons with tuberculosis per 100,000 population. Orange County has a population of 3.2 million. And then 2015 was our lowest number of cases on record, 162. We went up a few cases last year to 165 at a case rate of 5.2 persons per 100,000. But the thing is here, TB is not gone in Orange County. It affects certain populations, certain age groups. In fact, 91.5% of our TB cases are people born outside the United States. 8.5% are US born. Within those that are born outside the United States, we have 5 main countries in which they come from: Vietnam, Mexico, Philippines, India, and Guatemala. So in 2016, those were the top 5 countries in which people were born that had TB cases. And what we see is that these are countries where TB is still prevalent. So, in the countries, Vietnam, Mexico, Philippines, India, and Guatemala, there's still a large degree of tuberculosis within the society there. And so when they come over here, we get them treated and cured so that they can resume normal lives in the United States. So we follow the guidance of the Centers for Disease Control and Prevention. That's the leading public health body in charge of the United States, and that also was my former employer. So there's 3 specific priority areas in TB prevention and control. First and foremost, we want to find those cases. We want to identify TB cases and treat them to cure. Because we can't eliminate TB if we don't do the surveillance, do the treatment to cure. At the same time, we're looking at the contacts. Who is in contact to the TB case? Again, I talked a little bit about it already, but we want to find those contacts, test them, treat them. Again, treat that infection with either the isoniazid or the new regimen so that they don't break down with TB infection, the TB disease later in their life. Then the third priority is targeted testing and treatment for others with latent TB infection. Latent TB infection just means you had it prior to coming here. So, for all of the new immigrants that come into the country that go through the screening process, part of their screen is a tuberculosis screen. So when they come to the United States, we also do a secondary screening just to make sure that their x-rays are clear, and if not, then we get them tested and treated for tuberculosis, again, so that they can resume their life to the fullest of their ability in the United States. So these are our 3 priorities as a nation, as a state, and within Orange County. So just some other epi data. Over 6% of California's total population is estimated to have latent TB infection. So about 6 out of every 100 Californians. Among the more than 2.3 million Californians with latent TB infection, only 23% are aware that they have the TB infection, and only 13% have been treated. About 80% of our TB cases arise from reactivation of latent TB infection. Again, so what I mentioned earlier, so the TB sets shop in your lungs. It sets up the little factory in your lungs. And it just stays in there. I mean, it's a bacteria, but it acts like a parasite. As long as you're alive, that bacteria is going to just stay in that pocket, surrounded. You're going to keep replicating. You'll still have that TB infection until the day that you die. Once your oxygen supply ends, then the bacteria in that pocket will die unless it's treated with medication. But as people get older, and a lot of our TB cases are older, they get other medical conditions, or their immune system becomes weak in other ways. When that immune system becomes weak, that pocket breaks down that's surrounding the bacteria, and the bacteria then are free to replicate throughout other parts of the lungs and the body. So again, 80% of our cases arise from reactivation of latent TB infection. So if we can find people who have infection now, get them on and through a course of treatment, we can prevent that 80% of cases occurring from reactivation. And we've made some development at the state level. I'm part of the Tuberculosis Controllers Association. We've developed a risk assessment that we're trying to push out to the private providers in California. It's a simple 3-question risk assessment that they can do during physical exams. Are you foreign-born? Are you a close contact to a TB case? Or do you have an immunocompromising condition? And if there is a yes to any of those questions, then it's recommended that the person get a TB skin test or TB blood test. And then if that's positive, they get a chest x-ray. And if the x-ray is abnormal, they get put on treatment. So a simple way to try to routinize TB screening within the private sector. It sounds easier than it really is. It's harder to get new risk assessments out there, but we're trying to push from a state level on getting this out to providers so that, again, we can identify TB and get TB treated, whether it be infection or TB disease. So our ultimate goal is TB elimination. Last year, the TB cases dropped 3.6% in California. We still have over 2,000 TB cases in California. But we want to get to TB elimination. TB elimination is 1 case in a million. Pre-elimination is 10 cases per 1 million. So if you do some mathematical modeling, we would need about a 14% decline each year to reach TB elimination by 2040, which is possible. In prior years, there were 14% reductions at the state level. Last year, though, things slowed down a little bit. Again, there's a 4% 10-year decline. If we keep that 4%, we may not eliminate TB until 2057. That's the blue line. So 2114 would be the blue line at TB elimination. 2057 would be pre-elimination. So we are trying to make the decline, the slope of the decline, more steep, so we can try to get to 2040 for TB elimination. So again, March 24th is World TB Day. And that's when we sort of re-energize, remind ourselves from a TB community and those outside the TB community that there are a variety of ways to end TB. We need to test and treat people with latent TB infection. We need to mobilize and support. Public health can't do it alone. We need to develop and implement new tools. So even though we have a new blood test and we have a new medication regimen for TB prevention, we need to do more. We need to find that vaccine. The vaccine is the biggest thing that's been elusive to TB. That makes it unique. Again, because the bacteria so easily mutates, it's hard to find a vaccine that will work over time. We continue to need to do surveillance, track our progress, see where our numbers are going. We need to fight TB locally and globally, not only in the United States, but in also countries outside the United States. And we need to share our stories, to bring it to Congress, to the funding bodies, that TB is still here. We still need to be funded. We still need to find the research, development tools, and the public health tools to stop TB in order to find, treat, and cure TB disease. So again, our ultimate goal is to end TB by 2040, but it will take not only my generation of public health, but your generation of public health as well to make this happen. So at this point, I wanted to leave at least 15 minutes for questions that people have either about my presentation, or I'll also go into sort of what my path was into the field that I got into. So we'll start off with any questions about tuberculosis or the presentation. I'll be happy to answer those questions now.
Do you mind if we first give you a gratitude?
Thank you. Yeah, and actually, I mean, that's an excellent question. We get asked that question a lot. And within our clinic, we do not charge. We do not work with INS or ICE or any other enforcement agency. We're a true public health agency. So we actually have the opposite. We have people bringing in their relatives who are sick because they know our services are free. Now, if people have insurance, we'll bill insurance, of course. But if people are sick because of the public health implications, we'll treat them through, but we do not report to any authorities. Our building does not have any federal offices in it. We do have a sheriff in our building, but it's only for security purposes. But we have a good reputation within our community that this is a safe place to come for treatment, and that our only purpose is to cure you, whether you're here documented or undocumented. So we try to address any racial disparities that we have. We have, my staff is multicultural, multilingual. My staff comes from the countries that are listed. I mean, most of my staff are Vietnamese, Filipino. We're trying to get more diversified. So if you are, we can't find Korean. Spanish is hard to find because, once you're a public health nurse, you have more opportunity that could pay more. So we have a hard time actually getting Spanish nurses at times. Middle Eastern nurses, we can't find. So we have a hard time finding nurses. Nurses from India, China. So it's hard. We try to find staff within our population that they can relate to our clients. But we do have access to in-person and over telephone interpretation as well. So we're able to serve anybody that comes through our doors. But we like to treat them face-to-face if we can. So if you're in an underrepresented race or ethnicity thinking of public health, health departments are a good place for you as well because your services are definitely needed.
Health is one of the few areas in this world where we actually consider it to be a human right. So I think it's so commendable to me that our healthcare agency seeks to gain racial equity, and really tries to understand the compassion that's needed by healthcare providers. So I always think that's great. Can we give them a round of applause? There was a question back there before I.
Any other tuberculosis-related questions?
The blue T-shirt. Did you have a question? Oh no, sorry.
There's one here.
Ian.
In terms of the surveillance, how exactly do you spot
Okay, excellent question. Within California, tuberculosis disease is reportable by California state law. So any provider or laboratory who has a positive culture, somebody who has confirmed active TB disease, or is suspected of having TB disease is reportable to the health department within 24 hours of identification. So, physicians, laboratories are required by law to report to the health department. So that's one way we find out. The other one is people walk into our doors saying, I'm coughing up blood, I'm coughing, or my relative's coughing, they'll walk them in through the door. And then the other one is through contact investigations. We go to a work site or we do a household investigation. We do the TB skin test. It's positive. We do an X-ray. The X-ray is abnormal or you have symptoms. We identify cases that way. So either mandated reporting, either walk-in, or through contact investigation, or sometimes through targeted testing. Although we don't do a whole lot of targeted testing just because there's not the resources to go out and do blind testing within the community.
Do our prison systems do TB checks?
Both our jail, every person that gets booked into the Orange County Jail gets an X-ray through booking, so we can see if they have active disease. We don't look for infection as much in the jail system. We're lucky in Orange County not to have a prison, but the prison system does do a risk assessment. They used to do mandated testing, but they actually moved to a risk assessment because it's more effective. It's a more effective practice. Because one of the things with the skin test especially, you can get false positives if you test a low TB risk population. So it's better to do a risk assessment if somebody has risk factors, then you do the TB test. Again, either the TB skin test or the TB blood test. We get that request a lot. It's, hey, I got TB, you put me in isolation. How am I going to pay my rent? How am I going to buy food? So again, we encourage people to utilize their circle of family or friends. Again, health department doesn't have unlimited funds, and we can't pay for everybody's rent or mortgage. But we get from the state of California something called food, shelter, incentive, and enabler money. We get a certain pot of money every year that we can either help people with their rent or buy them gift cards so their family can buy food for them. We buy people bus passes so that they can get to the clinic. Ways to facilitate their treatment and their compliance. I mean, it's not easy to be stuck in your home. Again, it's usually about a minimum of 2 weeks up to possibly 2 months. And if people know that they need to go to work to pay for their mortgage, they'll be more likely to go and break isolation. Now, if people break isolation, we have the legal mandate to legally isolate them. We can house them in a hospital under observation if they don't comply. But fortunately, we don't do that very regularly. It's been years since we've had to go down the legal route to detain somebody against their will in the hospital. But it has happened. But most people are reasonable, and we're able to work with them, their family, and their friends to make sure that during that isolation period, they and their family can survive.
In terms of other infectious diseases in Orange County, how does TB rank in terms of the other infectious diseases that you monitor and track?
Yeah, it is. I mean, obviously, STDs are much higher. Gonorrhea, chlamydia, and syphilis hasn't been this high in years in terms of the number of cases and case rates. HIV, lower case rate than TB. We monitor about 85 reportable diseases that are state reportable in California. So TB is above HIV, but below STDs.
Do you want to tell them a little bit about how you got here as a way to close out this talk? Is Thomas here, by the way? Thomas is here? Hi, Thomas. Sorry, I just wanted to make sure you're here.
All right. So again, I have a Master of Science degree in preventive medicine from Ohio State University. So I did a research project, I did a thesis, and I graduated in 1992. So I was looking for a job, as many of you will be as well. And the Centers for Disease Control was looking for people to join them. And they came to Columbus, where I was at, and they did interviews. And based on my education skill set, I was fortunate enough to get a position with the Centers for Disease Control. A new program it's called a Public Health Advisor Program. The program is still around. It's changed a little bit, but it's called the Public Health Associate Program. And what it is with no knowledge or background in public health, they took me and 12 other people to Atlanta to be able to, in this case, learn everything there is about tuberculosis in 1 month. So we got on-the-job training on what is tuberculosis, signs, symptoms, medication, treatment, how to perform a skin test, how to read a skin test, how to perform directly observed therapy, how to do surveillance. So we got 8 hours a day for a whole month of nothing but TB training. At the end of that, we were then assigned to New York City. So this is back in the early 90s. In the early 90s, there were 2 things that were colliding at once: the HIV epidemic and the multi-drug resistant TB epidemic. They were colliding in New York City, and TB was sort of out of control. So the 12 of us were assigned to New York City, and we were spread among the boroughs. So I was assigned to Harlem. And part of my job was, the first day that I got at work was, back then they had the old computer paper, the green and the white paper that was this long. They gave me a stack of papers that was a foot high. It was literally a foot high, saying, these are TB cases or TB suspects. We don't know what happened to them. Can you find out what happened with them? So we took those lists, we divided them up, we worked with the hospitals. We were all assigned certain hospitals. I had Mount Sinai Hospital, Metropolitan Hospital, North General Hospital. on the west side of Manhattan. And we spent the next 2 years going through that list in addition to finding new cases and, again, testing people, getting people treated. I'm not a physician, so I couldn't, but I could perform directly observed therapy, watch people take their medicine. I could administer skin tests, refer them back to the nursing staff to get treated. And we were pretty successful in finding all of those cases. With the CDC, things are 2-year assignments. So at the end of the 2-year assignment, I went on to another assignment. CDC is still there today. In fact, I worked under Tom Frieden, who was the now former CDC director. And so after 2 years, I went on to a new assignment. And my new assignment was actually here in Orange County. So at that time, there was a multi-drug resistant outbreak at a high school in Westminster. And again, the CDC's job is to go into a place and to assist the local health department to be able to solve a problem. And this particular problem was contacts to MDR TB cases, and different population. These are high school students that were exposed. So I spent 2 years doing that, tracking. The same thing: skin testing, directly observed therapy, surveillance, education. And then after that 2 years was up, I had an opportunity to go to the state of Florida, work for the state health department in the TB Refugee Health Services program, in which, different role. This was the role of monitoring other health departments. So we were, I had the west side of Florida and central Florida, and the other guy that was out there had the eastern and some of the northern set of counties in Florida. Again, our job was to monitor the health departments and make sure that they were doing their proper CDC priority job. So after that roughly 2 years, an opportunity came up in Orange County again. So, I took that opportunity to come back, and actually didn't come back in the TB capacity. I came back as the senior epidemiologist for disease control and epidemiology, sort of looking at the 80 or so communicable diseases that were not TB, not HIV, not STD. So again, something different. So spent 5 years doing that, and then the TB manager retired. So then I moved into the TB manager position, just because that's what I know the best. That's what I was trained in, and it's also a much bigger program. Our TB program is a $10 million program, and I have 50 employees that I oversee. We used to have multiple clinics around the county, but through budget cuts, in 2013, when I was program manager, I had 5 sites and 101 employees. Now I have 1 site and 50 employees. Doing the same job, just everything more concentrated in one location. So, there are opportunities within public health. The Public Health Associate Program with CDC, there are a couple assigned to Orange County Healthcare Agency. One is dealing with health disaster management, and another one is dealing with more of the health promotion, chronic disease type of things. But again, the program's changed a little bit. You don't automatically get a job with CDC now. It's a fellowship program. But if you don't mind moving around a little bit and getting experience in different places, I think it's an excellent opportunity to grow in your public health.
Thank you so much. Please let's do it.
Thank you.